Well, a warm welcome to today's talk. It's Wednesday, the 16th of June. Now, I've got quite a bit of news from around the world today that I want to talk about, some quite important things to report, really. But before we do that, I was watching a Chinese film. Let's just call it a public information film, shall we? And let me just show you it, and we'll see the Chinese clinicians here doing their vaccinations. So here's the first one here. So the needle's in. Did you see that? She put the needle in. So the needle's in. And see that? She's drawing back. Just a quick draw back like that. And then she injects it. After aspirating. In, draw back. You see that? You see, they're doing it so quickly because they're highly skilled. So needle's going in, drawing, then draws back, and then injects. In, draw back, then inject. In, see that? They're doing it so quickly and skilled it's hard to see. So in. So needle in, see a draw back there, no blood, therefore the hand goes to inject. I think you can see that fairly clearly there in these Chinese vaccinations. See the drawing back there, clearly drawing back before injecting. Maybe one more. In, yep, you can clearly see her drawing back. So in, draw back. Satisfied there's no blood, then inject. Now, that's the way I've been doing this and teaching this for 40 years, or more than 40 years actually. So I'm pleased to notice that the World Health Organization guidelines are not being followed in China. So let me just show you what can happen. We've looked at this demonstration before, but I'm just going to do it briefly. So if you go into the muscle, you're inadvertently in a blood vessel. You just draw back to see if you're in a vessel. And if you are, then immediately blood comes in, so you don't inject. It really is that simple. And we saw how deftly those Chinese operators were doing that. Now, of course, I've got my letter from Nadeem Sahawi here, who says we don't do it. At least my letter got to Nadeem Sahawi, the vaccine minister. So I still think that inadvertent intravascular administration might be a problem, but the government doesn't. It's not national policy. It's not World Health Organization policy. And yet the Chinese seem to know better. Interesting, I thought. Why are we not doing the same? Now, moving on to what is really... not many people have noticed this, but it's spectacularly good news. Let me just show you. This is Professor Sir Andrew Pollard, Oxford Vaccine Group. I think he's the leader of the team of the people that developed the Oxford vaccine. And these are direct quotes from him in the popular press. Well, at the moment, we're not seeing any evidence that I'm aware of any loss of protection over time after vaccination. I mean, this is just fantastic. He's saying that from the data in his possession at the moment, there is no reduction in vaccine efficacy over time so far. And we've had quite a bit of time now. So this is looking like the longevity of the immune response is going to be good. And to be fair, we did predict this on this channel quite a while back, actually, based on data from 2002, 2003 from SARS coronavirus 1 pandemic. So if this turns out to be right, and it's looking like it so far, it looks like we were predicted that correctly and optimistically. But we don't know yet whether boosters will be needed or not. Fair enough. We're still waiting because next week it could change. But next week, the immunity levels are unlikely to drop off a cliff. If they decline, they'll decline slowly. And so far, they are not. This is remarkably good news. Why haven't other people picked this up? We've also had a virus that's circulating, which will cause some mild disease in those who've had 2 doses. So the virus is still circulating. People that have had 2 doses of vaccine might get mild disease or asymptomatic infection. which you might think is bad. But of course, the whole point is that these people are protected, very, very massively, largely protected against severe disease, hospitalizations, things like that. So that's great. So if like I've had 2 doses of vaccine, so if I'm exposed to the virus now, the odds are I'll be asymptomatic or minimally symptomatic. You might think that's bad, but no, I'm being exposed to the virus again, the same antigen that I was exposed to twice during 2 doses of vaccine. And that's just the same, essentially the same as giving me a booster dose of vaccine. It's like giving me a 3rd immunological stimulus, and that will boost my immunity. So that is a great natural booster of immunity as the virus circulates amongst those that have been doubly vaccinated. The vast minority of them are being made ill by it, way, way small minority. Most of them are just going to benefit and become more immune. So it's another really good thing pointing to a better way forward. And that will actually boost their immunity as well. So the professor agrees with me, which is always reassuring. So we're actually in quite a good place at the moment. We're not seeing any failure over time, waning of that protection. So far, we're not seeing waning of protection over time. And, we're like 7-8 months in now. And as well as that, of course, Professor Andrew Pollard will have access to data from the clinical trials as well, which of course are going back over a year now. So this is looking like the immunity is lasting for over a year without declining at all. And I think it could last for several years, as I've been predicting for some time. And it's just remarkably encouraging. Now, having said that, because I've had 2 doses of vaccine, I'm not going to go out of my way to expose myself to the virus. But you could argue, I'm not arguing, but you could argue that actually makes sense. I'm not doing it because it's not government guidelines, but you could argue immunologically that for the minimal risk, the absolutely minimal risk I'll get a bad symptomatic disease, it's much more likely to give me an immune boost and make me even more immune than I am already. I don't think we have evidence to predict the dates. So there he's talking about whether there needs to be a booster dose or not. So it's strange that was actually in a newspaper, but it hasn't really been picked up of what good news that actually is. So there you go. Be encouraged. I'm certainly encouraged by the longevity of response. Now, we haven't done a bit of an update from the UK, the United States lately. So let's have a quick look at that. So United States cases going down nicely. So what are we on there? We're on a 7-day moving average, 12,415 new cases per day. Massively down, not gone, but massively down. Now, deaths in the United States, tragically, have reached 600,000. It's not actually reported yet, but as of watching this video now, it is 600,000 or slightly more. But deaths there, so new deaths 219, 7-day moving average 292 deaths per day. So again, greatly down, but it has tailed off really quite slowly, as we see from the low curve of this line. So COVID vaccination status from the United States, at least one dose, 52.6% of the population, 43.9% of the population. I'm afraid President Biden's aspiration of 70% by the 4th of July is probably going to be missed. And we'll just look at why that's probably going to be missed on this screen here. This is the trends in the number of COVID vaccines in the United States. And we see that the numbers being given daily are down. Now it's still, well, that's the million line, isn't it? So it's literally just under a million, 934,654 in the day. That's back on the 9th of June. This is always a bit dated. So, but the vaccines are going out more slowly in the States now, unfortunately, meaning that the aspiration of the president may be missed. Cases and deaths, that's that link there. That's that link. That's that link there. They're all there. Click on them. They all work. Now, variants of concern in the United States. Now, the Delta variant, first discovered in India, is now officially a variant of concern in the United States as of yesterday sometime, I think. So here we have SARS coronavirus 2 variant classification and definitions. Lots on this site here. But here we see variants of concern, and the B1 617.2 Delta variant is now included on that list. Now, at the moment, it looks like it's about 10% of cases in the United States. There's no point showing you the CDC site, it's out of date. It looks like it's about 10%. But in another 10 days, that could easily have doubled. And of course, this is what happened in the UK. And now it's completely taken over in the UK. About 97% of cases now in the UK are the Delta variant of concern. And of course, this has caused a resurgence of cases in the UK. And I'm just hoping the United States does not go that way. Now, I am so pleased the United States has not suffered from the B117 Alpha UK Kent variant anything like as much as we have in the UK. We've suffered way worse from it here, but of course this Delta variant is even more transmissible than the UK Alpha Kent variant, and it's causing about 85% more hospitalisations as well. So it's quite significant, and we'll come on to the risks in the UK and that in a minute. So it's gone from variants of interest, it's now on a variant of concern. Now, there's another one here, variants of high concern. I can't quite remember what it stands for anyway. It's something like, variants of high consequence, that's what it is. Variants of high consequence. Now, at the moment in the UK and the United States, we don't have any of these. We have variants of interest and variants of concern, but we have no variants of high consequence, I'm pleased to say. But the question is, with the mutations that we're getting in this virus and the delay in vaccination around the world, will a variant of high consequence develop? And at the moment, that's an open question. We don't know. So is there a limit to the way that this virus mutates? Could evolution and evolutionary pressures cause this virus to mutate and then be selected for in a way that develops it into a variant of high consequence as opposed to variant of concern? I don't think anyone in the world knows the answer to that question. I certainly don't. But it's on the CDC website. So a variant of high consequence, prevention measures or medical countermeasures wouldn't work. So it would be very transmissible and it wouldn't work against medical treatments. It might not be picked up by our diagnostic measures. There might be significant reduction in vaccine effectiveness. And there might be high numbers of cases of vaccine breakthrough. That's doubly vaccinated people getting the infection. And another characteristic of it is more severe clinical disease and increased hospitalisations. Now, stress at the moment, we don't have any. The CDC here seems to be acknowledging its theoretical existence. Can the virus mutate sufficiently to develop into one? Basically, we don't know. Let's hope we don't find out. Now, on that point, the WHO, G7's pledge of 1 billion doses of vaccine, which of course we celebrated a couple of days ago, 500 million from the United States, 500 million from the European countries primarily and Canada. Dr. Tedros has said this is a big help, but we need more and we need them faster. So I tend to agree with him in this instance. Right now, the virus is moving faster than the global distribution of vaccine, largely due to the Delta variant. That is true. Let's hope we don't get a variant of high consequence that makes it worse. Whether we will or not, we don't know. 11 billion doses of vaccines are going to be needed to immunise 70% of the low-income countries by the end of 2022. 11 billion doses of vaccine. Wow, that is a lot. And that's an indicator of how far we still have to go, I believe. 11 billion doses of vaccine. That is, it's a mind-boggling number, isn't it? Now, in the UK, cases are going to rise in the UK. Now, let's have a look at, we've got the UK here. So let's have a look at the data here. So the cases will continue to rise in the UK. So vaccination is going well. This is the adult population, of course, whereas the United States quote for the whole population. But I'm afraid people testing positive was over 9,000 in the last 24 hours. And it's Wednesday, the 16th of June now in the evening. So that was the figure for the 15th of June, quite high, up 31.8% in the week. Hospitalisations still fairly low, but are going up. See, another 41% increase next week would not be good. Would not be good at all. So cases, when we look at that graph, yes, they're nicely down. Something went wrong. We can't see it. Okay, so I like that's the internet for you. So cases are way down compared to the previous waves, but there are indications that we're starting to enter a third wave in the UK, and it's all driven by this Delta variant. Deaths and hospitalisations are way down on what they were, but as we saw, they are unfortunately now rising again. So cases will carry on rising. How long? How far? How many? How many hospitalisations will this result in? Hopefully not too many, but basically at the moment we don't know. And on this point, Professor Graham Medley, London School of Hygiene and Tropical Medicine Diseases, is a disease modeller. This is his day job. Government risks are primarily based on the healthcare and whether the healthcare can continue to function. So the government assessments are based largely on how the healthcare system could cope. Personally, I'm more interested in whether I get sick or not, and I suppose you are as well, or our family members get sick. But this is what the government sort of planning is largely based on, according to Professor Graham Medley. Could return to seeing hundreds of deaths per day, he was asked. I'm afraid he says, I think that's quite possible. It's not a certainty. So he's saying that's possible. He says, I think there's a lot of uncertainty, but I think it's quite possible. And they're both direct quotes, actually. They should have been in italics. So these question marks are there. Will there be an increase in cases in the UK over the next weeks? Yes. Will there be an increase in hospitalisations? Yes. Will there be an increase in deaths? Probably a little bit. Maybe up to about 40 per day. But the vaccination programme is rolling out all the time. Illustrating that over 21s in England can now book a vaccine. Now, a couple of big debates going on in the UK at the moment. One is on mandatory vaccination, and the other is on vaccination of children. Now, Liz Truss, Cabinet member, it's incredibly important that staff in care homes are vaccinated. And we believe that Matt Hancock is going to make this, well, he is going to mandate this. So he's going to mandate, the Secretary of Health is going to mandate that people working in nursing homes be vaccinated. If you're not vaccinated, you can't work in one. Now, in London, the vaccination uptake amongst care home workers is relatively low. In other parts of the country, it's much higher. Not quite sure why that is. You might have some ideas on that, but quite low in London. We've got a hugely vulnerable population in our care homes, in our care homes, and making sure that the staff are vaccinated is a priority, according to Liz Truss, and Matt Hancock's taking it further, and that is going to be mandated, and they're currently discussing whether to make that mandatory for people in hospital. But of course, people in hospital who've had the infection, in my view, would only need one vaccine to give them a very high level of immunity, not two. So whether that's included in the guidelines, we'll see. Now, the highly emotive issue of vaccination in children. Pretty well everyone's got a view on this. And I get the impression the sort of momentum in the UK is probably going to go against vaccinating people under the age of 12. Now, we're not even vaccinating adolescents as we are in the United States at the moment. But just to give you an example of the debate here, Professor Callum Semple is a member of SAGE, interviewed on the media. Okay, he was talking in a personal capacity, but still a member of the Scientific Advisory Group for Emergencies, government scientist. We're talking about vaccination children here, mainly to protect public health and reduce transmission. So what he's actually sort of saying here is the main reason for vaccinating children would not be to protect the individual child. Now, of course, children can get severe disease. Children tragically can die from multisystem inflammatory syndrome, but it's incredibly rare. So Professor Semple here seems to be saying that the main reason to vaccinate children would be to increase herd immunity rather than protect the individual child. And this does raise a significant problem, because whenever I carry out a clinical intervention, my aim is to help the individual. And to foster herd immunity would be a completely different ethic. Laudable, of course, desirable, of course. But as a healthcare provider, I do feel that my primary thing has got to be helping the individual. What happens to the rest of society is not so much between the clinician giving the vaccine or prescribing the vaccine and the person receiving it. That's not so much part of that relationship. It's about an individual thing. So it's an interesting one. Teenagers are biologically more like adults. So teenagers transmit the disease pretty well like adults, he's saying. Thankfully, get much less frequency of severe disease. But the younger children really are not. They're about half to a third as likely to acquire the virus. So children half to a third, under 50% as likely to acquire the virus. And of course, if they don't acquire the virus, they can't pass it on. So pretty convincing rationales there for not vaccinating children. Of course, Israel hasn't vaccinated children yet, seems to be enjoying total herd immunity at the moment. Essentially no cases in Israel last time I checked. So that is interesting. Children half to a third as likely to catch the virus, and therefore half to a third as likely to spread it. And herd immunity would spread through schools naturally if the virus was there. And as we know, thankfully, children get minimally ill. The kind of unknown in that, the big counter argument to this is, we don't really know if a child gets a minimally symptomatic infection, what would be the risk of that child developing long COVID? And I don't know the answer to that yet. I don't think anyone does. If it turns out that asymptomatic or minimally symptomatic children can have a reasonably high frequency of developing long COVID, then to me, in giving a child a vaccine, I would feel much more comfortable about doing it for the benefits of that individual child. But I simply don't know that yet. I don't think anyone knows that yet. So this is Professor Callum Semple again. He's saying spare vaccines should be sent to countries that don't have enough doses. So that's another argument. So he says, I'm veering on not vaccinating children. So there you go. Now, seeing I've given you a flash of this, I'll give you the rest of it. Chinese vaccine rollout. First dose 44%, April 4.8 million doses per day, June 17.3 million doses. Wow, are they gearing up? That is an impressive increase. Yesterday they gave 19.8 million doses. Total doses so far heading towards 1 billion, 923 million. Beijing and Shanghai, the majority there are fully vaccinated. Many rural areas, nothing like so much. So going quickly in China, but patchy. Now, I've got news from a few other countries, but I think we'll leave that there for today. I'll leave that for now. I don't want to go on too long. That is the... I'm being kind, calling it a public information video for that vaccine technique in China. But in China, based on that film, they're not going to be giving inadvertent intravascular administration, whereas in the UK, we don't know whether we are or not. I'm not saying it happens very often, but I prefer it didn't happen at all. And why don't we copy the Chinese? I suggested copying the Chinese in wearing masks back in January, February. No, actually, I'm lying. It was about February, March. It was actually March the 7th, I think I suggested that. No, I think I suggested it in February, that if the Chinese are doing it, there's probably a good reason for it, because the Thais do it, the Cambodians do it, the Japanese do it. And there we see the Chinese using direct injection technique. Now, whether this is universal in China, I don't know. This is just one film. Were they on their best behaviour because they were being filmed? I don't think so, because they were so, it was all done so deftly, wasn't it? You could just see you go in, aspirate. You could just see it was part of their procedure. I mean, that's what I do when I'm giving an injection. You just go, when someone's injection, you go in, draw back, inject. It's automatic. I don't think I could really do anything else, and that's the way those Chinese clinicians were doing it. So good for them. Maybe the World Health Organization should ask the Chinese why they're not obeying World Health Organization guidelines on vaccination. But I'm personally pleased to see that they are not. Food for thought, hopefully more tomorrow. And of course, thank you for watching.